Hello everyone, and welcome to the webinar, Hotspotters in the HCH Setting, Managing Patients with Complex Comorbidities. My name is Molly Meinbreth, and I will be acting as moderator, host, and presenter for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of Special Population Health. This is a 1-hour presentation with the last 10 minutes reserved for questions and answers. Today's session will focus on the difficult task of managing complex comorbidities in patients who are homeless. I'd first like to introduce our speakers. I will be our first presenter as Program and Research Specialist with the National Healthcare for the Homeless Council. I've been working with the Council for over 4 years, taking on various roles such as Conference Planner, Clinicians Network Coordinator, and now Researcher. I'm currently coordinating projects on enabling services, chronic pain management, and complex comorbidities. Our second presenter today is Judy Mealey. Judy has been with the Mercy Medical Center Healthcare for the Homeless program in Springfield, Massachusetts since 1988, first as an RN and then as an NP. As clinical manager of the HCH program, Judy coordinates staff of NPs, RNs, case managers, and mental health therapists that provide care to people experiencing homelessness in a 3-county area in western Massachusetts. Judy is a longtime member of the Council and has participated on various clinical and research committees, developing the Council's documenting disability training, and she's also presented regional HCH conferences in the past. She has also received a local hero award from the Clinicians Network. Our last presenters are from United Neighborhood Health Services, a federally qualified health center in Nashville, Tennessee, Bill Friskus-Warren and Crystal Carey. Bill Friskus-Warren is the Director of Services for Homeless People for United Neighborhood Health Services, with 2 healthcare for the homeless sites in downtown Nashville, Tennessee. He serves on the planning and policy committees of the Council as well. Crystal Carey, LPN, works as the Clinic Director for the East Cluster of United Neighborhood Health Services clinics. She has 20 years of experience in the healthcare field, including ambulatory care, pediatrics, and corrections. Crystal developed an interest in public and community health while working in local county correction settings and has been in her current position for 6 months. Just like to thank the presenters, and I will now begin the presentation. This is just an overview of our webinar today. First, give background on this complex comorbidities project, and then a quick review of the literature. And then we'll go over results of field interviews that we conducted within the HCH field. And we'll highlight the Mercy Medical Healthcare for the Homeless program with Judy Mealey. And then we'll also highlight United Neighborhood Health Services with Bill and Crystal. And then we will end with a Q&A session. So what was our approach in taking on this topic? Clinicians in the Healthcare for the Homeless Clinicians Network had expressed challenges in providing care to patients with complex comorbidities. And it was stated that limited clinical guidance was available in providing care to patients with complex comorbidities. So there was a desire to explore promising practices and evidence-based practices in the field. So we conducted interviews with Healthcare for the Homeless projects to learn what others were doing. And we'll be presenting results of those interviews today. First, we conducted a review of the literature, and so for the next few minutes, I'll be going over results of that literature review. We looked at complex comorbidities within the general U.S. population and then also within the homeless population. So treating chronic conditions can be very challenging for patients who are homeless and their providers because of barriers to healthcare services and self-management resources that these patients experience. And chronic disease management is further complicated with the presence of comorbid conditions. As the Healthcare for the Homeless clinicians reported, that serving patients with complex comorbidities was their most pressing challenge in a previous survey conducted within the network. So the purpose of this literature review was to learn more about the prevalence of, management, challenges related to, and healthcare delivery models tailored to what we looked at in the literature review, multiple chronic conditions. So based on the 2006 Medical Expenditure Panel Survey, it was estimated that 28% of individuals in the United States have multiple chronic conditions. And just a note, I'm using the term multiple chronic conditions for this section because that was the term most often found in the literature review. In other parts of the webinar, we'll be using the term complex comorbidities because that's how the Clinicians Network it was sort of discussing, how they're discussing this topic. But the Medical Expenditure Panel Survey is a group of large-scale surveys providing healthcare use and cost data, including insurance coverage on individuals and families, their providers, and employers. And multiple studies have shown that the prevalence of multiple chronic conditions increases with age. So it wasn't surprising that 67% of fee-for-service Medicare beneficiaries who are over 65 years old or under 65 but received disability had multiple chronic conditions in 2008. That was 67% of those beneficiaries. However, prevalence rates will vary within each study depending on the method used to measure multiple chronic conditions. Documenting multiple chronic conditions using a predetermined list of conditions will provide different results than documenting all diagnoses found in a medical chart review. A simple count of conditions, however, is not as good a predictor of health outcomes as a model that considers the severity of the chronic conditions and their interactions with other conditions. So one example of a validated and reliable scale in measuring multiple chronic conditions is the Charlson Index. And the Charlson Index does not provide data on specific combinations of conditions or the prevalence of multiple chronic conditions in a population, but it considers the severity of each chronic condition per patient and has been shown to predict one-year mortality. So to illustrate this, I wanted to show you the top 5 combinations of morbidities found in patients using the Veterans Health Administration services from a 2007 study. 41% of the participants had multiple chronic conditions, and almost 6% had 4 or more. And as you can see here, the top 5 clusters of 2 chronic conditions were diabetes and hypertension, ischemic heart disease and hypertension, depression and osteoarthritis, and so on. But when you look at the top 5 clusters of 2 chronic conditions with the highest age-adjusted 5-year mortality rates, those combinations change. And so you can see here that those combinations with the highest mortality rates, the top one was cancer and COPD, cancer and diabetes, cancer and ischemic heart disease, and so on. And those percentages there are the mortality rates compared to the 7% that was shown for the whole sample. So these results show that a simple count of chronic conditions will not provide a complete picture of the situation because each specific combination of chronic conditions will result in very different health outcomes. As the number of chronic conditions rise, healthcare utilization rates rise. According to the Medical Expenditure Panel Survey, 4% of individuals with 0 conditions were hospitalized compared to 6% of those with 1 condition, 10% with 2 conditions, and 27% with 5 or more conditions. And similarly, 4% of Medicare beneficiaries with 0 to 1 chronic condition were hospitalized compared to 14% of those with 2 to 3 chronic conditions and 66% of those with 6 or more conditions. In addition, post-acute care visits, home health visits, physician office visits, emergency room visits, and hospital readmission all increase as the number of multiple chronic conditions increase. And all of these increases in healthcare visits result in major cost differences between individuals with multiple chronic conditions and those without them. Also, caring for patients with multiple chronic conditions can be difficult depending on the types and severity of the conditions in question. One researcher found that psychological distress was not related to multiple chronic conditions when counting the number of chronic conditions, but that it was significantly associated with multiple chronic conditions when considering the severity of the conditions. And psychological distress can lead to an increase in the experience of pain, limitations in physical functioning, disabilities, and lower levels of adherence to treatment plans, which could result in decreased positive health outcomes, increased disease complications, and increased mortality rates. A more recent study by the same researcher showed that the specific combination of respiratory and cardiac conditions results in an increased risk of lower health-related quality of life. In a review of Medline publications on multiple chronic conditions prevalence and associated healthcare challenges, researchers found that the coordination of care for patients with multiple chronic conditions was very difficult because of the high healthcare utilization rates and the variety of services utilized. Also, patients with multiple chronic conditions will most likely prescribe greater numbers of prescriptions than their counterparts with no or one chronic conditions, and this is a situation that could lead to increased adverse drug events. Furthermore, patients with multiple chronic conditions may find self-management of conditions difficult because of the many and potentially opposing recommendations for care, as well as the financial burden of taking care of those conditions. A literature review looking at medication adherence interventions for patients with multiple chronic conditions showed weak evidence for those using educational and behavioral techniques. So high-quality care for individuals with multiple chronic conditions will require improved coordination of care, interdisciplinary care teams, focusing on the health impact of specific combinations of conditions, use of care managers, and the inclusion of psychosocial support components to disease management interventions. And I just wanted to touch briefly on some policy recommendations developed by the Robert Wood Johnson Foundation in 2011 for addressing multiple chronic conditions. And those were expanding insurance, supporting improved communication between medical and mental health providers, including mental health services and medical homes, developing new financing methods, building a trained workforce, and prioritizing prevention. So in looking at the literature on individuals who are homeless, I found a major gap in just finding out what the prevalence of multiple chronic conditions were. And I noticed that there was a lot of focus on dual diagnoses, so individuals with mental health and substance abuse issues, but less emphasis on other combinations of morbidities. So a study from 2008 with veterans experiencing homelessness provides details on specific combinations of multiple conditions from a predetermined list of 13 conditions. And I wanted to show you all what this looked like. The top combinations, as you can see, were drug abuse and alcohol abuse, tuberculosis and alcohol abuse, hepatic issues and alcohol abuse, and so on. And what those percentages mean that of those participants diagnosed with the first condition listed, the percent with the second item listed had that other condition. So of those who had drug abuse issues, 78% also had an alcohol abuse issue. But not all the conditions measured in this study were chronic, but the data is still useful in that they provide a clear description of the comorbidities seen within the subpopulation of individuals who are homeless. Much of the literature on multiple chronic conditions in individuals who are homeless were related to dual diagnosis, like I said. And for example, the Collaborative Initiative to Help End Chronic Homelessness study in 2010 estimated the prevalence of dual diagnosis to be 52% among individuals who are homeless. And then another study of individuals who are homeless dually diagnosed and had been recruited for a trial of assertive community treatment in 2003, participants with schizophrenia were more likely to test positive for hepatitis B. And then researchers in 2011 found that veterans who were homeless were more likely to have poor mental health and quality of life outcomes if they were dually diagnosed. Another study in 2006 compared the health outcomes and costs of 3 programs on dually diagnosed individuals who were homeless, looking at integrated assertive community treatment only, and a standard of care, the control group. These authors found that participants in the treatment groups were significantly more satisfied and experienced more days in stable housing than their counterparts in the control group, but there were no significant differences in mental health status and substance abuse between the treatment and control groups. However, there were significant improvements over time for all groups. So these authors recommend that care teams be integrated and include full-time substance abuse counselors. Program administrators should incorporate additional intervention strategies to improve care, such as supportive housing arrangements, psychotropic medications, contingency management, and community reinforcement approach for addressing substance abuse. Investigators from the aforementioned collaborative initiative to help end chronic homelessness study described strategies that service providers use to address dual diagnoses. And these were stabilizing patients by helping them acquire housing, taking care of basic needs and supporting daily living activities, taking a thorough medical history before engaging in specific interventions, increase access to services, so medical, mental health, and substance abuse services, utilize motivational approaches to encourage participation in care, incorporating trauma-informed care, providing opportunities for peer support and group treatment, and implementing integrated mental health and substance abuse services into treatment programs. And lastly, utilizing interdisciplinary care teams and ensure regular treatment planning meetings, cross-training, multiple service locations, and partnerships with other community agencies. And then the portion of the population with the multiple chronic, I'm sorry, I also wanted to mention that even though they use these strategies I just listed, there are also challenges in working with their patients with dual diagnoses, and those were there were client behavior issues that prevented success of the program. Providers needed more time to build trusting relationships with their clients, and they found that projects experienced a lot of staff limitations and also limitations in community resources, and that even if the programs were really intent on providing integrated mental health and substance abuse treatment, that their local communities didn't always support that. So lastly, I just wanted to mention that as the multiple chronic conditions increases with age, we're going to be seeing a lot more of multiple chronic conditions, and as life expectancy rises, we'll just see more of these issues. And so we need to develop innovative healthcare strategies for serving these patients in an integrated fashion. And the significance of this growing issue has led to the development of multiple chronic conditions, a strategic framework by the U.S. Department of Health and Human Services. And their four main goals are to foster healthcare and public health system changes to improve the health of individuals with multiple chronic conditions, maximize the use of proven self-care management and other services by individuals with multiple chronic conditions, provide better tools, and also to facilitate research to fill knowledge gaps. And that's exactly what the council is able to do, to conduct research to fill in these knowledge gaps about specific populations that may be more at risk of experiencing multiple chronic conditions. And so in an effort to do this, to explore this topic, the Clinicians Network interviewed 4 healthcare for homeless projects regarding their management of multiple chronic conditions, or as I'll now be calling them, complex comorbidities. So we interviewed 4 clinical and administrative teams from the following sites: Mercy Medical Center, HCH program in Springfield, Massachusetts, Peak Vista Community Health Center, HCH project in Colorado Springs, Colorado, Outside In Portland, Oregon, and Franklin Primary Care H.E. Savage Memorial Center, HCH project in Mobile, Alabama. In general, most of the sites appeared to be short-staffed. Primary care providers were present, such as physicians, physician assistants, and nurse practitioners, but there was a lack in social workers, mental health professionals, substance abuse counselors, and case managers. Additionally, none of the sites had certified peer specialists or care advocates. And while all 4 sites participating provided basic primary services to adults and children, 2 of the 4 were somewhat unequipped to provide a full spectrum of clinical services, including mental health services, substance abuse services, case management, housing, advanced labs, imaging, and diagnostics. Mercy Medical Center and Outside In were exceptions to this in that they both had more mental health, substance abuse, and case management services available than the other sites. All of the sites did provide psychiatry services, however, psychology, mental health professional, and counseling services were lacking. All of the sites did provide substance abuse assessments and individual counseling, but Outside In was the only site to provide a buprenorphine program and complementary and alternative therapies. Detox services were referred to outside agencies by all the sites except for outside in, which provided them by subcontract. And half of the sites provided a full range of case management services, including health insurance benefits enrollment, disability benefits applications, assessments for social service needs, short-term case management, intensive case management, and housing case management. And then we asked sites if they actively identified patients with complex comorbidities and to provide how complex comorbidities were defined. Even though all the sites reported that they did in fact identify these patients, there was not a consistent way of doing this across the sites. Mercy Medical identified patients during the weekly staff meetings, and clinical team would decide on a case-by-case basis. Peak Vista conducted internal inquiries using measures required for reporting for UDS, and staff documented conditions based on billing codes addressed during a visit, but only the first 4 codes can be entered, so inevitably some conditions are going to be left out and not documented. Peak Vista is trying to develop a protocol to avoid this problem and collect more accurate data that reflects their patient population. Outside In identifies patients with complex comorbidities through chart audits of housing and medical interviews, diabetes and pain management registries, and care manager programs. These patients are defined as those with advanced medical, psychosocial, and developmental challenges that interfere with their abilities to advocate for their care needs. H.E. Savage and Mobile also conducts chart audits and includes a problem list on the front of each patient's chart that is reviewed by the nurses. And they do not have an EMR, so they're not able to do that electronically. So we asked sites to estimate what the top 5 most challenging complex comorbidities existed at their sites. And this turned out to be a complicated question in that most of the sites didn't track this type of data, so they were just guesses. And additionally, the conditions, like I mentioned, were often documented using billing codes, and some projects were limited in the number of conditions that could be documented in one visit. But in general, I just wanted to show you all that these are the top clusters of complex comorbidities that the sites reported, and you'll note that mental health is included in each top cluster. And then also, the other most commonly reported chronic conditions reported were substance abuse, cardiovascular disease, diabetes, chronic pain, kidney disease, liver disease, and obesity. When asked about models of care to guide practice management for complex comorbidities, all of the sites reported using the patient-centered medical home model or the primary care home model, and 3 of the sites reported using chronic care model. The sites were then asked about clinical decision support guidelines as standards of care for managing individuals with complex comorbidities. None of the guidelines reported appeared to be tailored to individuals with complex comorbidities. For example, Mercy Medical uses state and national guidelines for chronic conditions such as National Heart, Lung, and Blood Institute, asthma, and hypertension guidelines, and Outside In uses the Cryptic Care Management Program for diabetes care. Sites were also asked about specific evidence-based practices for supporting the management of complex comorbidities. Again, the responses were not specific to complex comorbidities, but were more broadly related to the care of patients experiencing homelessness. Most of the sites mentioned using or training their staff in motivational interviewing, harm reduction, comprehensive care management, and trauma-informed care. Additionally, Mercy Medical Center has a smoking cessation counselor, exercise group, and a women's recovery group to address specific groups. And Outside In has a diabetes and chronic pain management, chronic disease management programs. All of the sites use self-management program tools and resources for chronic disease management. Mercy Medical uses a diabetes tool from the Health Disparities Collaboration. Peak Vista has a health education clinic facilitated by a nurse educator and dietitian at their community health center. And program performance is measured by A1C for diabetes, peak flow for asthma, etc. And Outside In uses their Cryptic Care Management Program, which is facilitated by physicians and nurses. They also provide pain classes and diabetes case management. And H.E. Savage uses printed handouts provided by a nurse practitioner. And performance is measured through quality improvement process at the main community health center. Community coordination, care care coordination seems to happen through team conferences, EMR ticklers, and ICD billing codes. So Mercy Medical has team conferences that you'll hear about in which all staff attend. And Peak Vista has an internal tickler program for their EMR. They also have a twice per week check on highly acute situations until a level of stability is reached. And then there are 6-month follow-ups after that. And case conferences are rarely used, but when they do occur, staff included are shelter staff, the provider, mental health staff, and the patient. And outside-in reviews billing codes determine how to place patients into specific care coordination and refer them to providers. I need to wrap up, so I'm going to maybe skip over just a couple items, but I just wanted to mention that all of the sites reported that their agencies would benefit from training and technical assistance on how to better identify and manage patients with complex comorbidities. Currently, none of them are providing trainings to the clinicians around this specific issue, and ideas for training that were provided by the sites were sharing HCH models for increasing the capacity to identify and treat patients with complex comorbidities, and so also looking at evaluating outcomes, developing a method for measuring complex comorbidities or multiple chronic conditions, and then being able to track that, test that tracking system within our Healthcare for the Homeless projects, and then providing assistance to better utilize the EMR for tracking and following up on care. Thank you, and I'd like to pass the microphone to Judy now, who will be discussing how they care for their patients with complex comorbidities at Mercy Medical.
Thanks, Molly. As Molly said, my name is Judy Mealey. I'm going to spend the next few minutes talking about our approach to patients with complex comorbidities and then review a case study of one of our patients. This is a picture of our staff. Our program has been around since for 29 years. Our grant actually comes through the Public Health Department in Springfield, and we subcontract for medical, mental health, and case management services. Our staff is a staff of 18. We have a combination of nurses, nurse practitioners, and physicians. Our mental health staff includes a psychiatrist, a mental health therapist, and a psychiatric nurse practitioner, and our case managers are medical case managers. We have 26 sites that we cover, one full service clinic in this building, which is the Worthington Street Shelter. It's in the largest city in our catchment area. We cover 3 communities in western Massachusetts and cover 1,800 square miles, and it's a mix of urban and rural population. And this is just a picture of exam room in our new clinic, which is only 2 years old, so it still feels like a new car. When I talked to Molly about this webinar, Hotspotters, my first reaction is we do that, and we've always done that. And I don't know if anybody has read Atul Gawande's article, Hotspotters, but if you haven't, I would highly recommend it. And he makes 2 salient points in this article. High medical cost does not necessarily equal good health outcomes, and complex social needs have a negative impact on health outcomes. Homelessness. At a conference several years ago, I heard a comment by somebody that has always stuck with me. Homelessness creates or exacerbates chronic disease, and conversely, chronic disease causes homelessness. Healthcare for the Homeless programs are uniquely suited, I believe, to take care of patients with complex comorbidities. The first is a gift of time. Unlike your traditional medical clinic that has to see patients every 15 minutes, we do have the ability to spend a length of time with a new patient or with a complex patient, which I think we've all experienced. We have a team approach to patient care. There is no one person that's the top of the totem pole. We all work together. Our programs tend to be very flexible, and we care for patients no matter what their situation is. It's true patient-centered care. We care for our patients no matter where they live and no matter what their needs are. We believe that everyone deserves the best quality of care. We never give up on patients. We very seldom have ever had to turn patients away from our clinic. and if they fall off the radar, we still continue to try to find them and welcome them back when we do find them. And we believe we do whatever needs to be done to meet the patient care needs. I think the key to the Healthcare for the Homeless program at Mercy's success is our team meetings, other than having a fabulously caring staff. Everybody, all the disciplines attend our team meetings, and everyone has an equal voice. Any member of the team can propose a patient as a hotspotter. The item on our weekly team meeting agenda is the hotspotters. We update current hotspotters weekly, and we revise the care plan as needed based on patients' changing goals and the health status noted by the staff. We also have a motivational interview moment at staff meeting when someone has had a good experience with motivational interviewing with a patient. And lastly, our staff is very open and honest with each other around issues such as boundaries, the direction that a care plan may be going in. It's very easy to get over-involved with a patient, and we help ground each other. So who are our hotspotters? This is a picture of a patient that just arrived in a wheelchair, obviously multiple problems, and will probably be what did turn out to be a hotspotter. This is a loading dock where some of our patients tend to sleep to be protected from the elements. The patients who are our hotspotters are patients with chronic disease or even a severe short-term illness, along with broader issues of addiction, mental illness, lack of resources, social isolation, all of which negatively impact on their quality of life and their ability to function. And I think in the data that Molly presented, the issues of addiction and mental health are so much greater in our population than it may be in the general population. Our patients who become hotspotters often have frequent ER visits, multiple providers, some of them have no providers, and they all have complex issues. Hotspotters can also be identified by other agencies who may flag a patient and ask us to look into someone because they have concerns. Another resource we have is called the High-End Utilizer Meeting. It takes place with some of the staff from local emergency rooms, detoxes, service providers, and some of the forensic mental health people from the court. And they identify the top 10% of utilizers of emergency rooms in the area hospitals. They may not all be our patients, but a significant number of them are. The tools that we use with our hotspotters are patient engagement, which is absolutely vital to any Healthcare for the Homeless program. The patient's engagement in developing a sense of trust is vital down the road in them making any changes. It can often be frustrating, and it always interests me when we have a new staff person who will say, how can I get this person to do something? And the real question is, how can I help this person want to make a change in their life? Motivational interviewing, we've had full staff training on motivational interviewing, and that's also an incredibly valuable tool, as well as patient-centered goals. We cannot make goals for our patients. We know that doesn't work. The framework for our care is the chronic disease model, and I noticed that several of the other homeless programs use this as well. When I first saw it, it fits so well with the care that we give, because it identifies systems, agencies, and services appropriate to meet the needs of our patient and doesn't focus only on our system. It recognizes broader issues that impact the patient's life. So combining that with informed active patients and prepared proactive teams, it's all a lot of words, but when it's put into practice, it really does improve patient outcomes. This is a camp in the woods down by the Connecticut River where one of our hotspotters who's now housed lived for a very long time, a very bad diabetic. If anyone does not have a copy of the 2007 publication by Sharon Morrison on self-management support, it's a wonderful tool on a resource for practical applications of motivational interviewing. It was sort of focused around diabetes, but really works for pretty much anything else. Measuring our success, engagement is still the absolute key. We look at HRSA measures, obviously, patients' A1Cs or their blood pressure control. Patient identifying improved quality of life is an important measure of success, as is patient meeting an identified goal. This is a patient in one of our clinics. The strengths, I believe, of our program are the electronic medical record. It's been a blessing and a curse. It has helped us track our patients, certainly, because we have 26 sites. We used to lose patients all the time. So at least now we can track them a little better. We can flag patients in our system. We can put in care plans that everyone can read. So that's really been helpful. We have embedded mental health in our program, which is invaluable. If we see a patient in the clinic with an acute mental health need, we can have them seen the very next moment. We have a nurse that is a substance abuse specialist. We have the smoking cessation counselor, so we have some programs embedded in our clinic, which is terrific. We have a hugely strong outreach component. We have a nurse that you saw some of the slides from our outreach, and teams can go out. Our goal is to bring them into the clinic eventually, but again, that engagement piece, it may take a while for that to happen. And again, the team approach and complete the respect of all disciplines for each other's input. The weaknesses, I have to put the EMR there. It doesn't work as well for us as we'd like it to. The problem with the not being customized enough for us, community barriers always still hold with practices that are uncomfortable seeing our homeless patients, and the education that we need to do around that. And the chronicity of chronic disease may sound simplistic, but it's a difficult problem to have for people in a homeless situation. The case study I'd like to go over briefly is Richard. He is my most current hotspotter and still a work in progress. He is a 49-year-old homeless man. He came to us 10 months ago. He was discharged from a mental health unit after a suicide attempt. His medical issues include chronic alcoholism, depression, multiple suicide attempts, avascular necrosis of both hips, chronic pain from above, neurogenic hypotonic bladder. He only voided every 12 to 18 hours, diabetes, and tobacco use. He had no social support. His shelter situation was tenuous due to the mental health and substance abuse and his mobility issues, poor social skills, and he's functionally illiterate. So he's been a 10-month work in progress, and the success is that he has had both hips replaced. His initial goal was housing, but he had no income, and the history of substance abuse and mental illness were a barrier. Pain control was a problem for him and a problem for us, as the NSAIDs weren't working, but with someone with his situation, narcotics were tenuous at best. He has now been sober 5 months, and he had a one-time relapse. We're working on Social Security disability for him. He's stable on his mental health meds. He's still a work in progress. He's a high relapse risk. He still has no permanent housing. He still needs bladder surgery and has a lot of other social issues that he's dealing with. With the help of a team of our patients, as well as a team of our providers, as well as a team from the outside, which included outside mental health, transportation issues, the rehab staff, housing specialists, mental health. He has an intensive case manager from outside. He has been able to progress to the point where he is. And we are still going to walk this walk with him, and hope he continues to progress. And with that, I thank you for your time, and I would like to turn the mic over to Bill and Crystal.
Thank you, Judy. Crystal and I are going to spend the next 5 or 10 minutes talking about routine care and the management of comorbidities, and then we'll open things up for questions to all the participants. Encouraging patients to seek routine and preventive care is very much at the heart of what Healthcare for the Homeless projects do. Yet at the same time, we spend so much of our time responding to acute and urgent needs in our patients that it can be really easy to lose sight of just how crucial the provision of welcoming and hospitable clinic environments are to the management of comorbidities, and thus to keeping folks out of places like the emergency room and the cemetery. This is especially the case at one of the handful of clinics that Crystal manages here in Nashville, where they focus exclusively on chronic diseases like diabetes and hypertension, and really need to make sure their patients return somewhat frequently to the clinic to stay on top of their conditions.
Yes, it basically ends up being a whole plan. To be welcoming and encouraging to the patients, you first have to have the right environment. You have to have the right staff hired. So it begins first with your mission. The people that you hire, are they ready to be, do they know what it means to work in community health? That begins in the interview process and in training. We help and coach them and manage any kind of misperceptions that they may have, any resentments that they may have. And then we hope to have a really welcoming environment in our clinics that is a place where patients want to come to. If they want to be there and they come back, then we have more of a chance of being able to treat the chronic conditions that they have. Every chance that we get, we educate the patient on how important it is for them to follow up, what their disease process is expected to be, why it's so important for them to take their medications. And because we know that we may or may not see them come back, we really try to do everything we can do in a one-stop visit, which means back to the training of the support staff as well as clinicians, that we have got to treat this patient as a whole patient every time that we see them, their whole situation. We do referrals for behavioral health, and we do have diabetic case management in place at this time. It is hard, to do outreach with this population, so we try to get them whenever we have them there. Patient participation, if it's inviting and welcoming, you're more likely to get them to participate in their own health care. And so we just kind of keep going back to that with be hospitable, treat people with dignity and respect every time that you see them, and try to just keep it as a whole, a circle of how that we train them and treat the patient and keep them coming back each time. I think that's it. Do you want to go ahead and do questions and answers?
Okay, yeah, thank you, Bill and Crystal. So I quickly wanted to show everyone resources that the Council has related to this topic. We have our adapted clinical guidelines. We have various Healing Hands articles on comorbidities, and we also have some monographs with information. So please visit our website. And also, just to prepare you for our survey that we're going to ask you to fill out after the webinar, we'd just like to ask you, what resources do you need in your practice to help you provide care to patients with complex comorbidities? And also, what resources can you share with us that we can then share with the field that your project is using to provide care to patients with complex comorbidities? And please feel free to ask us now during Q&A or also in the survey. Please feel free to respond to these questions. So we'll now start the Q&A session. And the first question is there a way to access the literature review regarding complex comorbidities? And I'll go ahead and answer that really quick. I'm developing a report of the summary of the literature review and the results of the field interviews, and that will be posted on the Council website very soon. So hopefully we'll send out an email to our membership when that's posted online, but you can also just refer to the clinical resources section of the Council website for that in the near future. We have another question. Sorry. And this is for Bill and Crystal. Monica and Lisa are asking, can you say more about the welcoming environment? What about it is welcoming, and are there any particular design suggestions?
Well, actually, we are in the middle of remodeling and doing renovations to several of our clinics. And Bill's already had a big renovation. His clinic's all nice. But to get away from the feel of the free clinic where you have to go, and for it to be somewhere where you want to go. It's your doctor. It's the doctor's there. They're going to fill my prescriptions. They're going to take care of me. It's just a different type of mentality from the staff as well as the layout. The new renovations are just like a private physician's doctor's office, more so than I have one clinic that is still really old and is going to get renovated, and there's a huge difference in how you feel when you walk in the door of that clinic from the 70s than something that's renovated. And it's just a different feel for the patient as well. They feel like you think they're important, that you took the time to paint and make it welcoming. You've got some magazines, that you got something up to date. We have, just a little bit friendlier environment, I think. And also you hear hospitality, but it is something, there's difference when you're stressed and you're understaffed. I think staffing is always an issue in healthcare, period. We try to make sure that our support staff, who are the first people who greet a patient, want to be doing what they're doing. You have to want to do that. You have to want to help people, and it shows in your demeanor. And so that's a constant for the clinic directors. We're constantly sort of gauging that. Is this person in the right position? Do they need a break from being on the front desk and dealing with high stress and high volume every day? Does that answer the question?
I think that's sufficient. Thank you, Crystal. The next question is for Judy. How did you engage your case that you presented, Richard, in care and keep him in care?
Hi, Molly. Thanks for the question. Richard came to us through his intensive case manager, and so we began to work with him medically, and frankly, I think the first way we were able to engage him was controlling his pain. And we did it very cautiously with narcotics, which our program almost never does. And I think that said to him that we really did hear what his main problem was at the time. And the second thing I think we did to really engage him was we were able to advocate to get him into a sober shelter. And beyond that, I think the biggest compliment I got from him, at one point I stopped to see him in the rehab where he is right now, and he said, you people at your program really care about people. And I think that's the message that Crystal mentioned, when you have a welcoming atmosphere, and I think when you have welcoming staff that really care and want to help people, they notice, and that's the beginning of them wanting to care for themselves as well and increasing their own respect. Thanks. Back to you, Molly.
Thank you, Judy. The next question, I think probably Judy, Bill, and Crystal could all answer, and we'll give everyone a chance. But Carla asked, what are housing barriers due to? Is it due to resources or the patients not wanting housing? If they're not receptive to housing, how do you handle that? And Bill and Crystal, why don't you go ahead, and then we'll see if Judy has a response.
Thanks, Molly. Well, we don't have enough affordable housing in Nashville for the thousands of folks who are experiencing homelessness in the city and in Middle Tennessee. And resources are major as well, and then the supports that people need. I think, too, that in your question, something I think you asked about whether or not people don't want housing. Sometimes when a person moves into housing and they don't have the adequate supports, they tend to isolate. And all the good work that they've done and that we've done with them over the months that they've been making the transition from the streets into housing gets undone. we had the chairperson of our Consumer Advisory Board died last summer, and he did great in all the programs he was in, the transitional housing he was in, but when he got his own apartment, his addiction came back, and his psychiatric nurse practitioner said to him that she believed that he was committing passive suicide by not controlling his diabetes. So he wasn't going to return to the streets, he swore, but moving into housing was very difficult, and we did not provide adequate supports for him, and he didn't make it. Oh, thanks, Molly. To you.
Thank you, Bill. I'll give Judy a chance to answer the same question about housing barriers.
Thanks, Molly. I certainly would support what Bill said about the issue of social isolation when patients get into housing. Often the homeless network is their only social support they have. As far as getting into housing, lack of affordable housing is also an issue here, and I imagine everywhere else. Many of our patients don't have sufficient income to afford housing. Poor rental history certainly is a barrier. All of our rental agencies in this area do query checks, and many people have bad query checks. And sobriety can be an issue if some places will not take people if they haven't had a length of sobriety, which is very difficult to do. I think on the good side, we have quite a lot of housing first units here that will take people and provide supportive housing, and we've had quite a few successes with the supportive housing. We actually have one of our hotspotters who's housed, and for the first 3 months he was housed, he slept on his couch with all of his bags of belongings around him because he had never had, in years, had a space to call his own, and to move to the bedroom was just too much space for him. And it's been a long process, but that has been fairly successful. So there's a lot of barriers, getting people into housing as well as maintaining them in housing. Thanks, Molly.
Thank you, Judy. Another question from Mirnalini asked about one of the sites used a disease registry to assist with care coordination, and that was from the field interviews. And she asked if it's possible to get in touch with this site. That will be possible, and we can also list contact information in that final report that goes out. You can also look on our website in our HCH grantee profiles for Outside In in Portland, Oregon. But we can definitely get anyone in touch with folks who participated in the field interviews and any of our presenters today. The next question I think can also go to all of our presenters, and it asks, how are you able to invest sufficient time in a patient with multiple chronic conditions given limited staff? And I'll go ahead and let Bill or Crystal or...
I can answer that. We have to be able to afford it. It's a little bit different question, I guess. We treat every patient that way, homeless or not. We want to try to treat the whole patient. And so we do have a chronic disease clinic. It is not our allocated homeless clinic, but we try to company-wide treat people the same no matter which specific clinic they're going into, which is we try to do some when we know the homeless clinic does not specifically have appointments. Our chronic care clinic does. If we have a homeless person who's going to follow up with us there and we can do pre-visit planning, we try to get as much done from go. You know, what history do we have? Do we have any labs? Do we have admission? We have a portal to Nashville General Hospital where we can access patient records from recent admissions where most of our underinsured or uninsured folks are going to go. So a lot of investigative work on the part of the MA who's working that patient up ahead of time, ahead of the visit, even if it is from the time they sign in until they come back, if that's all the pre-visit you have. For people who do have appointments, we also do like what's called a huddle. We do team approach with the provider, customer service representative, and an MA who are all sort of on this team to take care of a person, which means getting a really good history that as much as you can get from the patient. And like I said, just look back at any medical record and access to any other agencies that we have readily available and try to treat as much as we can while we're there. Thank you.
And Judy, if you'd like to answer that question.
I guess I would just have to say we find time to do it because that's what we do and that's what we have to do. We certainly try to utilize our team, all the different team members, to get the appropriate information, whether it's track down medications at a pharmacy or track down old records. We also try to do it in maybe step visits, where the first visit you might get the most important vital information, and then make sure that you've worked hard on the engagement piece, and then gradually address issues as they unfold. But it's what we do. If we had to do 15-minute visits, we just wouldn't exist. Thanks, Molly.
Thank you, Judy. And I just want to thank all of our presenters again, as this will conclude our Q&A session. Thank you for joining the Hot Spotters in the HCH setting, Managing Patients with Complex Comorbidities webinar produced by the National Healthcare for the Homeless Council. And also, don't forget to register for our upcoming webinar, Integrating Employment Strategies into Supportive Housing Programs, a look at employment models and recommendations for practice, taking place Wednesday, July 25th at 2 p.m. Eastern. I invite you to visit the National Healthcare for the Homeless Council website for a full listing of upcoming and archived council webinars, as well as other educational products. Thank you so much, and this meeting will now be closed.